All right, good day, listeners. Today is April 28th. My name is Tejas Shah. I'm a member of the Public Affairs Committee of the North American Spine Society and a current PM&R resident here at the hospital of the University of Pennsylvania in Philadelphia. I'd like to welcome everyone for the next installment of our podcast series, showcasing interesting articles from the upcoming Spine Line NASS membership magazine. Today, we're going to discuss the article entitled Brain-Computer Interfaces for Spinal Cord Injury, Technology Progressing Towards a Clinical Reality. You'll have the pleasure of hearing directly from the authors of this article, Mr. Kevin Davis and Dr. Iahn Cajigas. Our hope and goal is that the discussion will further expound on their compelling article in our upcoming journal. So first, welcome to both of you, and thank you for joining us. Let's start off with the first question. For our audience, please give us just a brief overview of your article.
Well, thank you, Dr. Shah, for having us. But regarding our article, we tried to review the last 20, 30 years of brain-computer interface research with a focus on how brain-computer interfaces are starting to be applied to help patients with spinal cord injury, mainly with a hope of summarizing the available recording technologies that are available and modalities, as well as some of the limitations that are at play both with the hardware and software. And lastly, really focusing in on where this technology is going to go in the near term to help patients in their home environment and their ability to restore function.
And do you have anything else to add, Mr. Kevin Davis?
Yeah, no, I think that's pretty much the point, that where the technology is and where it's going, and it's kind of the bright future ahead for it.
Great. Yeah, no, I think that's what I loved about the article, all these different things. It definitely gets people excited, especially people in my profession that are dealing with these patients after the acute care hospital stay. When they're in our rehab hospital, they have to figure out their disposition, their bowel regimen, bladder, and all that. So to see all this is definitely really cool, and shows you how much of medicine there is still to go. Now to kind of get into the more specific side of it, I was reading about the different modes of the brain signal recording. I know they expanded on the EEG and the MEA. Can you summarize just briefly the pros and cons of these brain recordings? And out of the three, if you had to pick, I'm not forcing you, but if you had to pick, what is really the most realistic chance of us seeing something in clinical reality?
Yeah, so I can touch on the differences between those two different methods. So in our article, we talk about electroencephalography or EEG, electrocorticography, ECOG, and microelectrode arrays or MEAs. And starting with electroencephalography, this is a method that's really largely used in research settings, and it's even being demonstrated promise in rehabilitation settings as well. However, even though it has a great temporal resolution, this really lacks spatial resolution. And the electrodes in this method actually sit on the surface of the scalp. And so you can imagine that we're trying to get signals from the brain, and we have the skull and the scalp that's in the way. And this spatial resolution that's low, it's really difficult to isolate where in the brain the activity is truly originating from. And this also results in things like artifacts. This includes movements, muscle contractions, eye movements, blinking, heartbeats, and other noises from the environment. And the methods for applying these electrodes include both dry and wet electrodes. And each of those come with their pros and cons. And this results in a fairly complex technical setup procedures. So if this methodology was going to be used outside of a research setting, it needs to be taken into consideration how easy or difficult it's going to be for a family member or caregiver to set this up for someone who would be using this as a BCI. And so these are some of the technical challenges that electric encephalography has. And so the next one is electrocorticography. So this is similar to electroencephalography, but in this case, the electrodes are sitting on the surface of the brain. And so we get closer to the source of the signal that we're interested in. And this really removes the effects of the skull, which kind of acts like a low pass filter and minimizes the effects of those artifacts that are seen in EEG. And if they're there, they're easier to remove. ECOG also provides a high temporal resolution and additionally provides better spatial resolution. So we're able to pinpoint a little bit closer the source of the signal that we're picking up. Most studies that use electrocorticography are obtained from data used in able-bodied patients who are undergoing invasive seizure monitoring. This is where the signal is often collected from, sort of as an opportunistic experiment. And the use of ECOG in these clinical settings is shifting more towards stereo EEG, where electrodes are placed through small holes in the skull. However, there's newer devices for epilepsy management. This includes things like the NeuroPace and other brain monitoring devices that are equipped with ECOG, which may make studying ECOG brain-computer interfaces more accessible in the future. In any case, because of the limited clinical settings in which ECOG signals are collected, more studies are going to be needed in order to determine how viable using ECOG is for BCI in the future. And lastly, we have the most invasive of these three, which is microelectrode arrays, or MEAs. The biggest con of this is that it's more invasive in terms of its surgery. The electrode shanks are penetrating into the tissue. However, this really comes with excellent temporal and spatial resolution, as the electrodes are pushed right up against the tissues and the cells that create the signals we're interested in detecting. And these electrodes can really isolate individual axon potentials from the individual cells or the collection of cells in that area. And the specific neuronal populations that emit these signals are typically tuned to specific behaviors or tasks. And so as a result, these BCIs that use this technology have been successfully applied at decoding very goal-directed information. Such as reaching or visual or auditory stimuli, we're able to decode that really well with a very high accuracy. But because of the invasive nature of these electrodes, as they penetrate into the brain over time, this has potential to degrade the signal as a result of gliosis along the tissue electrode interface. Most of the remarkable demonstrations that people may have heard of in the media often are accomplished with these arrays, such as those developed by BlackRock's Utah array. And the BlackRock teams are working to get these devices out of their clinic. And the problem with this is that the hardware to acquire these signals from these arrays is very large, and all the data that these arrays record really limits the mobility. So as an example, the standard Utah array has 96 channels recording at 30,000 samples per second. And so this means it's really recording, 5.7 megabytes per second or 19 gigabytes per minute. And so these are some of the pros and cons of all of these. And, if we had to really pick between these three, coming to clinical reality, I think it depends on what is attempting to be achieved. So do we really need the spatial resolution of microelectrode arrays versus more generalized signal from ECOG or EEG, and then also the surgical risks that are there. So it's really task and goal dependent on how these methods are going to be employed.
Got it. Thank you so much for taking us all through all three of those. I mean, it's very complicated for sure. And I like that. Every patient determines the case and what we're looking for. So to go through all the specific characteristics is important. You did touch on something that was also highlighted in the article, which are some of the difficulties with these devices, such as how hard it is to set up, the practicality of taking this home, and then of course the lack of mobility. So I'm glad you touched on that as well. Now, one thing I know it wasn't really talked much about in this article, but just something I know when you come to the software devices. One of the interests I have personally is in neuromodulation. And so they're looking at devices such as spinal cord stem, dorsal root ganglion stimulation, peripheral stem. And one thing they always harp on is psychological evaluation. Given, the literature review that both of you performed, what can you tell us about the psych eval and if that plays any role in determining what kind of devices these patients would be tried for?
Yeah, absolutely. I think this is a great question and super important anytime that you deal with patients that are in a difficult situation, particularly still in a research setting, and you're offering something that's going to try to address one of their main problems. So I think in the current studies that are out there, which rely on very small sample populations and very specific devices that are not really in the clinical arena yet, it is extremely variable whether they undergo rigid psychiatric psychological evaluation. But I do think that as you expand this to larger clinical trials, where we're going to try to systematically study the effect of a particular device on, say, restoring upper extremity function, it's going to be extremely important to screen patients so that they both understand really the risks and the limitations of the current device that's being tested, and that they're aware that, it's not going to be initially a complete solution. And you really want to make sure that they understand that where the technology exists so that you can really meet their goals and not really overpromise. Because as we really talk about in the article, these are just currently technologies in development and they're getting closer to a clinical reality, but it's going to require this sort of balance of give and take between patient and the clinicians to work together and really refine their own solution. So I think that it's going to be really important going forward on the larger clinical trials that we do incorporate a structured psychiatric evaluation on all of these studies.
Well said. And I certainly hope that as the trials become larger, that the psychological evaluations are, some of the primary and secondary outcomes of these studies as well. Because sometimes that, can't get brushed under the carpet. And as you know, you've seen patients all the time that, in your field are going to go through a surgical resection of a tumor, spinal resection. I mean, just low back pain in general. They just think the surgery is going to fix them, but then there's another reality on the other side as well. So definitely a great point there to address. Kind of sticking with the psychological aspect, these brain-computer interfaces have a huge ethical implication to it as well. You mentioned in the article some of the security and privacy concerns. First, I just would like either of you to maybe expand on that to let the public know about some of these concerns. And then any other concerns that weren't maybe addressed in the article that you may foresee coming on once this gets into the larger public area.
Yeah, certainly. I think that's a pretty big concern as it starts rolling out of the clinic, especially, right? So in the clinic or in the research setting, really, it's very controlled. It's not being used, constantly. And so the two most salient things that come to mind is really data privacy and also ensured secure control. So you can imagine that this would be someone using a prosthetic device. Let's say these are now out being used in the real world. And if there is a computer interface and with the growth of, Internet of Things, making sure that the signals from the patient are what's actually driving the system. So, if someone were to gain unauthorized access to that system, that they wouldn't be able to, drive that, remotely against their will, against their signals that their brain is emitting. Now, on the data privacy side, we've seen brain-computer interfaces capable of writing technology, right? Decoding the intent to write or do some sort of message. And so with that comes all of the data that they're wanting to communicate. And so if someone gains access to that data, it's similar to having a keylogger sort of installed on your keyboard and someone's monitoring every keystroke that you have. And so if someone has access to that, you can imagine how much information could be taken from an individual. Now, this is all theoretical right now, but important to consider once we push this technology out into the public. and these will be really important to address and make sure that it's secure. And I imagine that standard encryption protocols will be good, but as we learn more of what these devices are capable of and how they hook together and the systems that build them, we'll need to move forward as we learn more.
Yeah, most definitely. And I think a lot of this, obviously we talk about certain examples, some practicality in use already, but then there's also a big theoretical approach to it. So I know one of the things I hope is that the government is also sort of buying this policy as well to kind of regulate this as we go along. So we're not, this doesn't come out and, sort of get out of control. Because obviously those things that you mentioned could be quite concerning, especially in the wrong hands. Now, talking about the complication rate, especially with some of these devices that do involve some kind of a invasive surgery. I mean, you went through the different recording mechanisms, with MEA being the most invasive. Obviously, the complications we can anticipate would be surgical site infections. Now, are there any other complications that you'd be concerned about with these type of devices that would be different than the normal complications you'd get in any type of surgery, neurosurgery, for example?
Yeah, I can address that. I think, with all surgeries, I think the risk profile is going to depend on, really the site in the brain or in the peripheral nervous system or anywhere in the spinal cord that we're placing the device. So they're going to be related to the nearby neurostructure that might be at risk, as well as the nearby vascular structure. So things like neural injury, stroke, bleeding, infection all fall into that. And then the chance of damaging function that's currently there is huge, because a lot of these patients, they're already limited in function. And so if you're now going to an area of the brain that's working normally and you're putting that at risk, you need to make sure that you minimize any chance that you're going to take away any of their residual function in the process of doing this. There's also a real risk is the inability to improve function. I mean, these are you have the potential of now going through surgery and not getting a benefit. So I think, before these technologies leave the research realm, one big thing that needs to happen is that we need to be able to deliver something to patients that will give them enough function to give them enough benefit to outweigh the surgical risk. And with regards to the surgical risks, I think, the realm of things that we will see are similar to the types of things we see with deep brain stimulation. So those rates of complications range anywhere between 5 and 8%, depending on the series that you see, and include things like, device infection, device malfunction, lead migrations, lead fractures, erosions in the skin that can happen when a patient's nutritional status is sort of not optimal, as well as then device failure modes that can happen through just scarring around the electrodes from inflammation or micromotion or anything at the tissue interface. So those would be the sorts of risks to be considered, and it'll really be variable depending on the type of modality that we're trying to restore in a particular setting.
Got it. Yeah, and I think thank you for expanding on that. Kind of really ties into the whole psychological aspect, right? I mean, some of these patients come in with whatever functional deficits they have, and some the complications can make it worse. And of course, there's that risk-benefit ratio. And hopefully, as the trials become larger and larger, we can really take a closer look at that to hopefully evaluate the effectiveness of each of these different BCI devices. I want to touch on, so, there were some things mentioned in this paper, and it was really more of an overview. Are there ongoing clinical trials of any specific products that you can point to that we're really, looking forward to the results of right now that would be exciting and around the corner for something to look at?
Well, there's a couple of things that have been recently in the news. There's certainly a number of companies that are entering this space, including companies such as Neuralink, that's tied to Elon Musk, Stentrode, which is a endovascularly deployed brain-computer interface, is currently in clinical trial stages for control of computer cursor, for example. And more recently, the maker of the Utah Ray, the BlackRock Microsystems, received a breakthrough designation by the FDA that's sort of closing its path to being clinically available as a system to restore function after neurologic injury. So, there are many commercial things that are happening right now with regards to clinical trials. I did a recent review of clinicaltrials.gov. I think the Central trial is the one that's currently actively recruiting. The other companies have smaller studies that I believe are sort of preclinical or are starting to get into the clinical arena, but I did not see them listed there. But it's always a good place to go is to look at current spinal cord injury studies that are device related on clinicaltrials.gov.
Right. Well, thank you so much. Yeah, I mean, it'd be exciting to see, what the future holds. Now, some of these devices obviously have costs to it. And, when it comes through insurance authorization, we have to look at how much all this stuff costs, if it's really going to be worth the, functionality gains and all that. I know that we're still dealing in the very early stages of all this, but has there been any study done to look at healthcare costs? And is there anything we can point to quantify, the savings for patients, moving down the road, especially with spinal cord injury?
Yeah, there's been numerous studies done looking at lifetime healthcare costs of patients with paraplegia and quadriplegia. And we mentioned in our article, one estimate, which is that the range is somewhere between $1.2 to $5 million per individual in their lifetime in terms of healthcare costs. And of course, the costs increase according to their neurologic level of injury. So patients that are, tetraplegic that require a lot more daily care will definitely have larger costs. And so then the question becomes, depending on the amount of function that you're able to restore, how much independence you're able to achieve for an individual to then minimize those costs. And now specifically quantifying that and studies aiming to quantify that are lacking. And again, will need to be developed. Exactly these questions will need to be studied once the devices start becoming more mainstream.
Right. Yeah. For sure. And I think obviously this is something that we have to, pay close attention to. But wow, 1.5 to 5 million for so I think something you just cited is outstanding. And I mean, when we get these patients in our unit, whether they're traumatic brain injury, spinal cord injury, even post-stroke, they have so many things. There's so many different costs associated really with the quality of their life that, we have to figure out before we send them home. And so I can certainly speak to that. I'm sure you can as well. I mean, it's really just a different quality of life altogether that can lead to a lot of costs.
Absolutely. And what we're talking about here is this is a cost of their healthcare and not necessarily includes adjustments for quality of life, right? So, there are many benefits that can potentially be given to patients that you can't really put a dollar amount on. The ability to void on their own, the ability to feed themselves, those are things that, go above and beyond something that we could really put a dollar number on, but would mean a lot to any individual. And so I think there's certainly a lot of healthcare economics questions that need to be addressed, but also needs to be highly integrated with quality of life metrics for patients when they undergo participation in these studies.
Exactly. Yeah. And so it's like you mentioned, it's a big, very, very complicated, but hopefully we have the right goals to look at and to obviously account for risks and all that. I do want to kind of tie back into the ethical portion of this. Now we're looking at patients with spinal cord injury with functional deficits. So obviously, no one is going to think at this point of them receiving some type of advantage. But I know with devices such as Neuralink, another ethical concern is that we might be in the process of creating quote unquote superhumans and how that, kind of just going to the other side of the equation here. Is that something that in your literature review and your research in doing this paper that you came across, and what are your thoughts? I'd like to get thoughts from both you as a doctor and from you, Mr. Davis, as an engineer. What are your sort of outlooks on this, and what do you think the society as a whole has an outlook on it as well?
Yeah, so I can kind of touch on the engineering part first. So I think there's going to be a need to first. There's a lot of knowledge that needs to be gained first in order to kind of make that realization happen in terms of making superhumans, and then asking, how do you define a superhuman? I mean, that we could probably talk about that at length for how that's defined. But thinking of, whether it's going to be increased cognitive abilities, increased physical ability, mental abilities, social abilities, all these different things that, our mind allows us to do, and how that's going to be augmented, I think is going to really require to fill the gaps that we have in our neuroscience understanding of connectomics. How do different areas of the brain connect with each other? And even in engineering, how do we make sense of those signals in order to, direct those signals? So there's definitely a lot to be discovered first before we kind of make that jump to a superhuman.
What I would add is that, the ethics is going to be driven by us physicians and making sure that we apply these technologies in an ethical manner, and that we really understand those and have those discussions ahead of time, and not let the technology get ahead of us. You can certainly always develop interesting and cool technologies in the lab, but in the end, it is our responsibility as physicians to make sure that when those things make it to our patients, we do it in an equitable fashion, that everybody that needs it gets access to it, that it doesn't get used for, it gets used for the right purposes on the right patient. And, I think that's where really physicians and our physician training need to be kind of at the forefront of legislating for how these things are going to be regulated, and actually implementing them. And we need to work closely with industry, not sort of just taking what industry develops and bringing it to our patients, rather working hand in hand with them to develop this technology adequately.
Yeah. And on that note, I wanted to add one more thing too. Just, I was thinking about the ethics that come out of this, as the public gains more understanding of what these things do, there could be an array of imaginative ideas that kind of come out from the public. Whether or not those ideas are feasible, I think really need to be taken into consideration in terms of, how bad it can get. Because I think our imaginations are able to, produce a lot of good, but also, produce a lot of bad. And so whether or not some ideas that come out of that are feasible, I think that those are good things to kind of keep in mind from an engineering standpoint of, oh yeah, maybe I didn't realize this, and I need to, keep this kind of like how Dr. Cajigas said, like, what are those problems that we're going to be running up against before we get there, so that we don't, find ourselves in a bind that, wasn't something considered. So really, including public dialogue and making sure that, physicians are advocating the best that this technology can provide for patients.
Right. Those are great points, especially now with not just the medical field, but in every aspect of the field, how artificial intelligence has kind of taken a hold. And I don't know if we consider brain-computer interface as artificial intelligence. I certainly do, because I have maybe a more vague definition of it. Some people would consider us already artificial beings just with the use of a cell phone, because of how much that's changed our life functioning. So certainly something good to keep track of, and definitely like what you said, Mr. Davis, to obviously understand like what we have before we start thinking about regulating, but obviously to all, of course, from a medical perspective, to use this for the right reasons. You think about maybe the financial and financial differences that we have, and how that can interplay with some people having access to BCI devices as some others not, and that can create a wider class difference. So obviously beyond the scope of the article, beyond the scope of this podcast, but just something it just really opens up a Pandora box. I think obviously we're all have the right mindset. Now, this has obviously been a great podcast, and I kind of just want to, from each of you, again, kind of get your closing thoughts, and just kind of looking forward, looking to the next article that we have along this line. What would you say?
Yeah, so I would say that brain computer interface really has a bright future in general. that the field is evolving very fast. We find ourselves in a time where technology is developing very quickly. We're able to miniaturize computation at an incredible pace. Think about the advances that the iPhone in your pocket has had in the last 10 years and where it's going to go in 10 more, and the computation that you're able to do in things of that size. And now being able to scale that into implants that humans can use to improve their daily quality of life. I think it's a very exciting time to be in this or related field and really think about creative ways as physicians, as people that work with patients with spinal cord injury, of how we can use these new technologies to improve somebody's daily life. I think it gives us a lot of, it's almost sci-fi to some degree, the fact that you can think about maybe an idea that might seem crazy 15 years ago and actually be able to come up with ways to realize that idea now with the technology that we have available and some of the clinical devices that we have available. So I think it's definitely a field to watch. We definitely have to be involved as physicians to make sure that things are done in an ethical manner, and that we need to really leverage our relationships with industry, with engineers, so that we can better develop the technology so that it maximizes the functions that patients want to have improved. And, I think it's just, I find it super exciting. I can't wait to see where this is going to be in another 5 years, because I know we'll be very, very far ahead from where we are today.
Yeah, I just echo that I think Dr. Cajigas put it beautifully, that as people collaborate and make this happen, it's gonna be a bright future.
Great. Well, thank you so much to the both of you for taking the time out of your busy schedule to join us. Very, very exciting article. I encourage everyone else to check it out. I'm sure we'll include the link below this video or the podcast for people to see. And just want to say thank you again for your time. Until next time.